first case is she is Rimsha, 32-year-old female. She was married for 3 years and she was cohabitating since then. She had one abortion 2 years back and it was spontaneous conception. She had a history of missed abortion at 2 months. She had periods and that are regular and she is having normal flow. She is having history of hypothyroidism for which she is taking Eltroxin 25 microgram from the past 1 year. BMI is 24 and examination is normal. And the investigations, tubal patency has been done and it was bilateral free spill and husband semen analysis was also normal. AMH came out to be 1.46 and day 2 profile was normal and the diagnosis was planned, diagnosis was unexplained infertility and she was planned for OI and IUI. So as the first cycle has been shown, so she was started on tablet letrozole 2.5 mg for 5 days. So on the day 13 of her cycle, there was a dominant follicle seen on the right side that was 19.6 mm and the endometrial thickness was 6.9 mm. It was triple line. Then she was given injection HCG 10,000 international units IM. Then again she was called on day 15. It was seen that the right ovary was having a follicle of 20 mm and the ET was 7.5 mm in secretory. So I want to know that is it necessary to see for the rupture before we do IUI?
Okay, Neeraj, it's a good case of unexplained infertility. So I would say that it is not necessary to document the ovulation before you do IUI because the ovulation can happen anytime. I mean, it takes 24 to 30 hours post LH rise or the LH surge. Now we have given the HCG as an injection.
Yes.
So normally it can take 36, 40, 44 hours for the egg to rupture. So moreover, it depends, like you are saying, on day 13 and 15.
Yes.
So how many hours was the gap?
Yes, ma'am. So the injection was given at 8 p.m. on 22 August night. And then she was called at around 8 to 9 a.m. on 24. So it was almost 36 to 37 hours.
Yeah. So basically it is important. Normally when I plan my IUIs around like 40 hours, right? So I think I would like to give this as a take home message that do not wait for the egg to rupture. You can do IUI. I normally do it 40 to 44 hours and these eggs, they usually rupture. Maybe Dr. Nisha also can shed light on this.
Yeah, I agree with Dr. Shalini, though there are various studies which show that if you have a documented ovulation, the pregnancy rate is a little higher. But this doesn't mean that you have to make sure and do, make sure that the follicle has ruptured before you go for IUI. So many times we happen to do IUI without even making sure that the follicle has ruptured. Another thing which you can do is that give an injection of Fertigen 5000 or 2500 unit at the time of doing IUI also. So that will not only act as a luteal phase support, that will also enhance the chances of ovulation.
Okay, ma'am. Yes, ma'am. So, ma'am, in this, what can be the cause that we are seeing that this follicle is not ruptured when we have done?
So why do you say it has not ruptured? You are saying 7.5 millimeter secretory endometrium. So how do you say that it is not ruptured?
Ma'am, because when we have done the scan, then the size of the follicle was almost same.
So you mean to say that if the follicle, like the way of checking with scan is that the follicle should have collapsed or something? No, that's not true. Sometimes even if you have a follicle ruptured, even then the size may remain same, or sometimes even it increases in size. The only way to make sure that the follicle has ruptured is to check the serum progesterone level. Without that, you cannot make sure that it has ruptured. Neeraj, one more thing I wanted to point out in your history, maybe we should avoid taking patient's name. Just mention Mrs. X or Mrs. Y or something like that.
Yes. Okay, ma'am. And ma'am, we have... Yes, ma'am.
At times it is very difficult to predict also, like you've mentioned 7.5 millimeter as the secretory endometrium,
Yes, ma'am.
At times the endometrium is like, homogeneous, right, in the ovulatory, in the follicular phase also. So probably I would not say it as an unruptured follicle. I would say it will rupture. It is very difficult to comment I mean, yes, at times we can when we do see the changes, but we could be skeptical also, you know.
Yeah,
Okay, ma'am.
I think that ultrasound alone is not confirmatory of the rupture or unrupturing of the follicle. Sometimes you may see that there is blood flow and all with that. You may comment on that, but it is not a confirmatory test. The
Yes.
confirmatory thing only comes from the serum progesterone value that it has ruptured or not.
Yes, ma'am. Ma'am, so we have done the injection hormone test, and the hormones was estrogen was 92 and the progesterone was 1.92, ma'am.
So I think it has ruptured.
Okay, ma'am.
And 92, why the E2 is low? Because you have given letrozole.
Okay. So, ma'am, even with the formation of the dominant follicle, like single follicle, there can be less estrogen on the day we are checking. Is that possible?
If you have used letrozole, yes, definitely.
Okay.
There could the estrogen sometimes sorry, with letrozole sometimes the E2 values are low, and 1.92 means that the follicle has ruptured.
Okay, ma'am. And ma'am, okay, yes, ma'am.
Dr. Shalini, would you comment on that?
With letrozole cycles, the estrogen levels they really go down, you know, as
Okay, ma'am.
compared to the clomiphene cycles or the gonadotropin cycles, because the mechanism of action of letrozole is that only, that it is
Yes,
an
ma'am.
you know, cytochrome P54 inhibitor. So the values are really down in E2. I mean, when you give letrozole cycle. And yes, progesterone do signify that it has ruptured.
Yes, ma'am, because sometimes when the patient is really aware, they say that our follicle is almost the same. Doctor, should we go for IUI or should we not? Then we should counsel them regarding all this, right, ma'am?
No, you have to tell them that, even if the follicle has ruptured, there is
Yes, ma'am.
sometimes an increase in the size of the follicle also.
Follicle can be
So
there. Yes.
sometimes you see the follicle has collapsed, sometimes you see that the follicle has increased in size. So these are not confirmatory things. So I think you should counsel accordingly only.
Yes, ma'am. Okay, ma'am. Now is the second case. She is Mrs. M, 26-year-old female, married for 7 years. She is cohabitating since then, and she is having coital history 3 to 4 times per week with BMI of 22.8. Her investigations has been done, and the HB was 13, and blood group is B positive, and then all the hormones are normal. AMH is 3.68. HSG is suggestive of right tubal block, and HSA is normal. So the diagnosis was made of unexplained infertility, and she was planned for ovulation induction with intrauterine insemination. So this is her first cycle. She was given clomiphene citrate, 100 mg for 5 days. She was having polycystic ovarian morphology on both sides. Then on day 10, we found a right ovarian follicle, the follicle in the right ovary that was 19.8 mm, and the ET was 9.6 mm. And she was given a trigger, and then we checked on day 12. Then the follicle size was 25 and the ET was 9 mm, and the IUI was done, but she didn't conceive. So we have done her another ovulation induction, and in that we gave her letrozole 2.5 mg for 5 days. Again, the follicle was PCOM and 10 to 12 in left ovary. Then on day 10, she got a follicle of 20.3 mm and ET was 9.6 mm. Injection was given, and on day 12, the follicle was assessed. It was 26 mm, and it was 9 mm and secretory. And the serum progesterone was done. It was 8 nanogram per ml. So in this, I want the what can be the diagnosis in this case?
You tell me why did you say that it is an unexplained infertility?
Ma'am, because in this the follicle and one of the tube is showing the
But
swell and HSA
see,
is normal,
as an
ma'am.
IVF specialist, we know that the tubes are
One of
bilaterally affected
yes,
in most of the, like, it says 100% of the times tubes are affected. And tubal patency is not the only criteria. Tubal
yes, ma'am. It's
patency and tubal
internal. Yes,
functionality are two different things. So
yes,
even if the
ma'am.
tube is patent, when one of the tube is affected, we don't know, there is just a mention of spill. We don't know whether it was congested, not congested, what is the condition of the cilia. It normally the literature says that the tubes are affected bilaterally in 100% of the cases. So I would say rather than unexplained infertility, it seems like tubal factor infertility. Dr. Shalini,
Yeah. I mean, the unexplained infertility, you only say when the tubes are patent, the semen analysis is normal, and she's ovulating, right? So I think, and moreover, you're saying the polycystic ovarian morphology is also there. And probably you have, I don't know, because there are too many eggs. I think you haven't mentioned the antral follicular count, Neeraj, have you?
Ma'am, it was 10 to 12 on left ovary, and in right ovary, it was not counted actually. It was
Okay.
polycystic looking. Yes.
Because the AMH is also high. So most
Yes.
likely, instead of unexplained, it looks like a PCOS case
Okay.
with one tubal block. So I think unexplained infertility would not be the right diagnosis in this case.
Okay.
Now again, coming that both the cycles, they show the follicular dump of like 5 to 6 millimeter.
Yes.
also the why was the scan why scan was not seen on the left side?
Sorry, ma'am.
Why you didn't see the follicles on the left side?
No, it is mentioned.
No, we saw it was no, there was no recruitment on the left
Actually,
side.
no recruitment, but there are
Yes.
10 to 12 follicles on both sides. So
Yes,
basically, it
ma'am.
seems like a PCOS morphology.
Yes, ma'am.
Okay.
Ma'am, and I just wanted to know that the HSG was showing the tubal block on the right side, and the dominant follicle is also on the right side. So, what is your opinion? Like, should we do IUI if we are having dominant follicle on the same side of the tubal block?
No,
If going by this case, she's a case, if I take this as a polycystic ovarian morphology with the semen count as normal, now the pathology in polycystic ovarian is that there is no ovulation, right? Or maybe the egg formation is not there.
Yes.
So this single side tubal block is on HSG, right?
Yes.
Now the
Yes.
sensitivity and specificity of HSG is like close to 60 to 70%.
Yes.
In this case, I will not like to go ahead with the IUI because the dominant follicle is on the side where the tube is blocked. But
Yes.
having said that, I will ask the patient to have regular sexual contact, like I said, alternate days during the peri-ovulatory period. Because IUI does involve a lot of cost in the private setup also.
Yes.
So my take in this case would be just to tell them to try naturally.
Okay, ma'am.
Dr. Nisha?
I think I most probably would have a consultation with the patient and counsel them, and I will leave it up to them. If they go ahead, they want to go and do a intravaginal insemination or a timed intercourse, or even if they want to go ahead with IUI with proper consents and proper counseling and proper explanation that there is less chance. If they still want to take that, I probably would do.
Okay.
But Dr. Shalini is right. Theoretically speaking, if the tube is blocked on the same side, and it makes less sense to do the IUI.
Okay, ma'am. And ma'am, is there any difference in giving the trigger as 5,000 or 10,000?
No, 5,000 is more than sufficient in most of the cases. 10,000
Okay.
is not needed. This has been proven multiple times that if it is effective, 5,000 dose is more than enough.
Okay, ma'am. And was the management like in first cycle we have given the clomiphene citrate, and in the second cycle we switched to letrozole. So was that fine, or should we have done something else?
No, that is fine, I think, because but why did you change? I mean, of course, the first line of drug for
Yes, ma'am.
polycystic ovaries is letrozole, but you have given clomiphene citrate. There was a dominant follicle with the clomiphene also, and the endometrium thickness was also good, right?
Yes,
She is
ma'am.
probably
Just
tubal
like
hypertension.
trying one or two things that maybe one drug doesn't work, the other works, though letrozole works a little better in polycystic cases because
Yes,
there is a monofollicular development
yes,
mostly as compared to the clomiphene citrate cycles, right? So,
yes,
the doing IUI in PCOS patients probably gives an additional edge of like say 10%. So that's what Dr. Nisha said, that it has to be a good counseling with the patient. You explain, and if it is a how much life, married life, 7 years, right?
yes, yes, ma'am.
okay, then that's a very long time actually.
I would probably not do 2 cycles of IUI in this
Yeah.
case. I would probably explain her that most probably it is a tubal factor and she needs to proceed for a little aggressive management.
Yes, ma'am. Ma'am, actually, in our setup, we have to weigh both the things. So we offer them initially 1 or 2 cycles of IUI if other things are fine. But yes, she's having long married life, ma'am. And
I
ma'am,
think counseling is the most important thing. You need to explain
yes,
to the patient very well.
yes, ma'am. And ma'am, how to diagnose whether it is a luteinized unruptured follicles or it is a corpus luteal cyst? Is there any way to differentiate?
You already did that test,
Okay, ma'am. Okay.
serum
All right.
progesterone.
Yes, ma'am. And ma'am, if we diagnose a case, like if there is any case of luteinized unruptured follicle, then how do we counsel our patient and what should we do in the next cycle for our patients with this?
It is actually very difficult to say, and it is not always the same that one follicle you are seeing that the follicle size has become big, and as Dr. Nisha said, that increase in follicular size also at times, it can be like the egg has ruptured. So there are cycle to cycle variations, but yes, we do see patients when they are very persistent about it that doctor, okay, my egg doesn't rupture. Every cycle I have the documentation and it doesn't rupture. So to be very honest, luteinized unruptured follicle is truly, I would not say it does exist in every cycle, but if yes, if the patient is saying very categorically, then probably at times, I have tried giving antagonist and then giving the HCG trigger. Antagonist maybe in a small dose, especially just half a injection of antagonist, because that brings down the your LH levels, and then if you are giving the HCG injection, it tends to rupture. Like in cases of IVF, we do follow.
Okay, all right, ma'am. Ma'am, is there any role of diagnostic laparoscopy for this?
You can go for double maybe trigger also. Try if that helps with agonist and HCG both. That also
Yes.
is a possibility.
And ma'am, the third thing you told, we can do that also, like on the day of IUI, we can give another that will work as
Yes.
luteal support also.
Yes.
Yes. And ma'am, is there any role of laparoscopy for this?
For LUF, no. But that laparoscopy is a
Ma'am,
operating.
sometimes-
I think if you have another reason for which you need
Yes,
want to
ma'am.
do laparoscopy, then it is a different story. But just to diagnose LUF, you want to go for laparoscopy is not. I wouldn't say that it is recommended.
Yeah,
Yes, ma'am.
especially with such long fertility, 7 years of infertility, and where there is no endometriosis, because at times we do see that
Yes, ma'am.
follicles there might be poor ovulation in cases of endometriosis because
Yeah,
there are additions.
that is another. Dr. Shalini is absolutely right. That
Yeah.
is
Yes.
another factor. Adhesions and all that. That also scarring. That also leads to such kind of picture sometimes.
Yes, ma'am. Yes, ma'am. Okay, ma'am. And that was all.
I think it was a wonderful discussion. Dr. Nisha, Dr. Shalini, and Neeraj, and the questions were very rightly put across, very, very practical points. So, I think the conclusions would be luteinized unruptured follicle. To say that, first of all, we should be sure. And if it is the first, cycle of IUI and you feel the follicle is not ruptured, you should ideally go ahead. But if it is repeatedly happening, you are being referred a patient by a gynecologist, she has closely observed the patient that every time the follicle is not rupturing, patient is not getting pregnant, then don't waste time and go ahead for IVF, because persistent LUF, you have to go for IVF. Second thing, which Dr. Nisha very rightly said, that tubal disease, tubal disease is generally bilateral. So keep in mind that the functionality of tube and patency, these are two different things. And this LUF, is known to happen in two situations very often. One is PCO, second is endometriosis because of adhesions. And if you happen to do laparoscopy for some other reason, you can look for adhesions and you can, kind of take care of these adhesions and your patient may work. But the case like this, where the couple is married for, so we know that IUI chances, once one of the condition is married for more than 3 years and trying and not conceiving, this goes in favor of persistent LUF with this extra condition with unilateral tube functioning goes in favor of IVF. Now, as far as dual triggers are concerned, literature does not support it. And, even giving an extra dose of, that is called bolus dose of trigger on the day of IUI, again, literature does not support, but all of us are trying that, it ruptures somehow, but it is not being supported by literature. So before we hand over to Dr. Sharma sir again, Dr. Renu
Can I ask a
there
question?
and she has, ma'am, please say whatever you want to say, please
I
add.
wanted to ask a question. I'm a little confused. When you're doing follicle monitoring, you say that the follicle doesn't have to regress or doesn't have to rupture to consider ovulation. Well, that is what we are doing in follicle monitoring all the time. So you say that there is a follicle size 20, 22. What do we do? You keep doing serum progesterone to find out this is unruptured follicle, this is ruptured follicle. How do you differentiate?
Nisha, you want to answer?
I'm very confused.
Ma'am, basically ultrasound cannot for sure tell you that whether the follicle has ruptured or not. There are various ways. You can look at the cumulus oophoros. You can also look at the vascularity around it, but no ultrasound. Ultrasound is not a confirmatory mode of rupture or not rupture. So we check at other points. For example, we check for fluid in POD. We check for vascularity. We check for regression in size. And then, yes, if you want to make sure and confirm, then serum progesterone is one thing. But if you, the basic thing is that if you have done it 2-3 times follicle monitoring and you see the similar pattern and you don't get the desired result, maybe we should not stop patients. We should not waste patients' time. And
that is a completely different thing. Obviously, you would move on.
Yes.
The standard follicle monitoring, you find either regression or rupture to say that the patient.
Most of the times, yes, ma'am. But ma'am, it is not considered confirmatory if the size has suddenly increased. We cannot say that it is unruptured follicle or the other way around. Only if it collapses, we can say, okay, fine, ovulation has happened.
Sudden increase in size of the follicle, like in this case, 19 to 25 and 20 to 26 is also a sign of LH surge actually.
Yes.
But then there should be some corpus luteum like features, no? Not.
Ma'am, हर बार नहीं आते हैं. They don't come all the time.
Dr. Sharma, what is your take on that?
Yeah, you're right, madam. Actually, the pattern of the follicle would change after the rupture. And unless, it has again swelled up because of internal bleeding, so you would see the echoes inside. And
then you see it different.
Yeah. Otherwise, you see the cartoon type of pattern in the corpus luteum. So that is where you can make out that this is a corpus luteum and this is a unruptured follicle. So one can differentiate if you look into the echoes also. Just adjust your
absolutely
this thing gain in the ultrasound machine, and if you find that the echoes are there inside, so that means most likely it is a corpus luteum. But if you find it is a hypoechoic inside, then it is a follicle.
But sir, this is always not true for all the follicles.
In science, you always have gray areas.
That is true. But there has to be a standard protocol how you do follicle monitoring. No? Otherwise, you can't be doing all these things for follicle
you can be able to make out. But definitely, there are some telltale signs to differentiate between the two. But then 1 or 2 cases you may not be able to make out.
I feel if it is happening for the first time, you can still give it a kind of benefit of doubt. But if it is repeatedly happening, then ma'am is right. Then you cannot say that, it is increasing in size every time. We have to consider it as a case of repeated LUF.
Yeah. So
the other thing,
but if it is repeating every time, maybe there is no harm in checking the progesterone level once and see.
Yes, you can do that.
Yeah,
certainly. The other thing, if you say that the patient has 1 tube patent and you are allowing her, you're telling her to have intercourse because there is enough evidence to show that even from the contralateral ovary, the tube can pick up. So why not do IUI?
That's what I said, ma'am. We can try doing IUI.
Yeah. If you're...
Ma'am, the incidence of pickup of contralateral egg I think the transperitoneal migration, I feel it is very, very less. I somehow
I
now
think
in
somebody will
favor of-
have to look up into the data and say, we can't just say from our feelings, what,
No,
how
no,
we
no,
feel.
it is not feelings, ma'am. It is the data which says the transperitoneal migration, the incidence is very, very less.
How much?
I think it
Very,
is just
oh, you,
0.1 to 1 or
okay, you say it's
3%,
very less.
ma'am. Yes.
Then that means we should counsel the patient beforehand that if you are forming a follicle in the contralateral ovary, we will not go ahead with IUI. Is that right?
That is what I mean, especially in cases of PCO, that is what my choice is. Or I counsel that in this thing because HSG, the sensitivity and specificity is just 65 to 70%. So, I mean, like it cannot be 100% proven that the tube blockage or coming on HSG is a blockage only.
No, that is a different matter. The point is that, I mean, people do conceive with one tube after self-injectomy, having one tube, and there is data to show that there is not much difference in pregnancy rate after self-injectomy.
Ma'am, but we have to remember
That's a
that
different thing,
here
ma'am.
there is
That's a different
another
thing.
condition. We have a
Self-injectomy,
doubt
yeah.
that the follicle is not ruptured. So then
No,
going
no,
ahead
no.
for
I'm not talking about the follicle now. No,
No, no, ma'am.
different, completely different.
I think we can explain it to the patient and can go ahead. And
Ma'am,
we have to really individualize.
salpingectomy and vis-a-vis like salpingectomy and the follicle developing on the ipsilateral side. Yes, the patients do conceive easily. But here the debate is that the contralateral dominant follicle and the tubal blockage.
So that's what I'm asking. Should we tell the patient, counsel her before that if you form a follicle on the contralateral ovary, we will not be doing IUI? Should that be a standard counseling? That's what I'm asking.
No, madam, I just want to add something on that. Especially the patient who are from poor class, they have already spent some money and you find that egg is forming on the opposite side. So if you're not doing, the semen count is okay. If you don't do IUI, it's okay, but ask them to have intercourse and ask her to lie on the left side. If the tube is blocked on the left side, so by gravity, the right tube also may go towards the left ovary and may pick up. The chances of pickup is more if she runs. So normally what I do is that I tell the patient, especially for the poor class who cannot afford again and again the stimulation. So I tell them, okay, you have if the semen count is okay, or if they want IUI, after that I tell them, okay, you lie down most of the time on the left side. So there is a possibility that your right tube, which is patent, may be able to pick up the egg from the opposite side. So the transmigration will become more easier than just lying horizontally. That's one thing. And secondly, sometimes we find that the follicle is not ruptured. And that time, by putting a transvaginal probe and hand on the abdomen, do the bimanual sort of compression of the follicle, and you find suddenly the follicle has ruptured and collapses. So especially because there are different category of patients. Poor patient cannot afford again and again. So maybe this will also help because we have done the manual rupture now. Now how much it will be effective, because to pick up the egg, that's a different story. But at least the follicle sometimes do rupture by doing this bimanual pressure on the follicle.